A 68-year-old woman is referred to you for evaluation of a murmur. She tells you she was diagnosed with a murmur and an abnormal heart valve as a young woman. She takes antibiotics before visiting the dentist, but says she feels well. She walks 2 miles every day without symptoms. Her physical exam shows something interesting. First of all, her systolic pressure is a little elevated at 145, and her diastolic pressure is very low at 48. So there are several things that could do this. Very stiff arteries can give you this wide pulse pressure, as could a valvular lesion, aortic insufficiency, or also called aortic regurgitation. The pulse is regular and at a reasonable rate. Fingertip oxygen saturation normal. JVP is normal. Jugular venous pulse, that is, quite normal. Carotid pulse is very brisk. The brisk carotid pulse and the wide pulse pressure are suggesting to me this patient may have aortic insufficiency. Her lungs are clear, so there's not heart failure. And heart sounds, she has a grade 2 systolic ejection murmur and a grade 2 diastolic murmur heard at the upper right sternal border and no S3, again consistent with aortic regurgitation. The systolic murmur doesn't mean she has aortic stenosis, it's just because of the increased flow that goes across an abnormal aortic valve during systole. So let's imitate that. So normal heart, lub dub, lub dub. Here's her lub ch dub, lub ch dub, lub ch dub. So you heard there's 2 murmurs, the systolic ejection murmur because of turbulence from the large flow going across the aortic valve, and then the diastolic blowing murmur of aortic insufficiency. She has no peripheral edema, so there's nothing in the exam or the history that suggests heart failure. So what's the critical factors here? She has a history of heart disease, so you're going to be looking for a valvular heart disease. And, of course, her physical exam shows you a wide pulse pressure as well as signs of aortic valve disease. We do a chest X-ray, and then we'll do a Doppler echo. Here's the chest X-ray. Her left ventricle is enlarged. You can see, again, the apex is pushing out towards the chest wall, but the lungs are clear. And in aortic regurgitation, also one has an enlarged aortic root, and you can see that on this view of the chest X-ray, the dilated ascending aorta. And here's the Doppler. You can see in the rainbow color area a large amount of aortic regurgitation flowing across the aortic valve. Large regurgitant jet across an abnormal aortic valve. Other options, her blood tests are all normal, kidney function's normal, which is good. So the conclusion in the echo is that she has moderately severe aortic insufficiency. She has a bicuspid aortic valve. 1% of the population is born with a 2-cusp aortic valve rather than a 3-cusp. And the bicuspid aortic valve wears out early, sometimes associated also with ascending aortic aneurysm or dilation of the ascending aorta. The left ventricle is enlarged but has normal ejection fraction, so normal functioning, and she has an enlarged aortic root, which is quite common with a bicuspid aortic valve. The bicuspid valve can go on to either stenosis or regurgitation with time. In this case, it went on to aortic regurgitation, and the left ventricle dilates in order to pump the larger end diastolic volume into the aorta because of the blood that flows back into the left ventricle during diastole with the aortic regurg. If the aortic regurgitant volume is very large, left ventricular failure can eventually develop, and that requires replacement of the aortic valve. Using prophylactic antibiotics for dental work or surgery has been a controversial area. Some countries have actually shown when they stopped doing this prophylaxis, the incidence of endocarditis went up. This was not the case in the United States, but there are still many practitioners who prophylax patients with bicuspid aortic valves with antibiotics. There will probably never be a double-blind randomized controlled trial here. So again, this is often shared decision-making with the patients. I tend to use prophylactic antibiotics with patients with bicuspid aortic valves, but many of my colleagues do not.